go. Welcome everybody to The Big Idea. This is Dr. Jeffrey Hanna. I hope you are doing well today. So what is The Big Idea? This is where we look at some health medical research, try to distill it down into plain English so that you can capture the big idea and understand it for really two groups of people. Number one, healthcare providers, who should probably know this information. But number two, people who are experiencing these different kinds of issues so that they understand what options may be available to them that otherwise they don't know about. And this particular week, what are we looking at? We are going to be looking at Meniere's disease, Meniere's syndrome, health outcomes following cervical specific protocol in 300 patients, and I will add consecutive patients in this particular case, with Meniere's followed over 6 years, written by Dr. Michael Burkhan. This one here I think is going to be very important because if anybody out there experiences Meniere's or has a family member, you've probably been told that, they don't know really what's causing it and there's not really a treatment for it aside from taking medication or basically doing dietary modifications. Most miserable ones: no alcohol, no salt, no caffeine, any of the good sins or the pleasures in life. And what Dr. Burkhan finds and describes in this particular article here is that that may not necessarily be what the true underlying nature of the condition is. Yes, these are all triggers, but there might be something going on, a little bit more about that we need to take into account and take into consideration. So, per always, let's go ahead and rip through the abstract, the summary at the very beginning. Here we go. Multiple factors and several common triggers contribute to Meniere's disease, but the hypothesis of this study is related to one cause: an upper cervical subluxation complex, the result of whiplash trauma caused by a vehicular accident or blow to the head. They looked at vertigo intensity rated by 300 patients on a scale of 0 to 10, with 10 being the worst imaginable. Prior to treatment, mean score was 8.5. 6 weeks post-treatment, the average was down to 3. After 1 year, down to 2. 2 years, 1.4. 3 years, 0.9. And 4, 5, and 6 years, 0.8, an improvement of over 90%. 97% claimed a dramatic improvement in vertigo. 3% had side effect of a headache. That's kind of a big deal for, again, a condition that seemingly has no known cause, let alone no known proper solution. Now, I actually recommend you do have the opportunity to read through this particular article if you get the chance on your own, and we'll give you the link here. Why? Because this article is written in plain English. It's got a couple of technicalities, but Dr. Burkhan does a really good job of breaking it down into the core messages so that really anybody can have a much better understanding of what is going on. But we're only going to hit on some of the high points here so you get some of the takeaway. So let's have a look at a few things here. So Meniere's, described as a syndrome, and I'll come to that a little bit later, with hallmark symptoms, and there's 3 of them: vertigo, tinnitus, and deafness. Was first, reported on in 1861. Now, a differential diagnosis, I'm skipping ahead a little bit here. A differential diagnosis of Meniere's disease is a subjective diagnosis of exclusion. When all other possible diseases with the same symptoms are excluded, the condition is called Meniere's disease, which is actually more appropriately referred to as Meniere syndrome. Syndrome being a collection of symptoms, nothing more. Okay, so what does this mean? It means that people can start to experience vertigo, tinnitus, deafness, any of these different things here. They go to the GP and they say, maybe you had a little bit of a virus, try a few of this. If the problem doesn't go away, they're referred to either an ENT or a neurologist. They have a look, they're going to refer for either a CT scan or an MRI of the brain. And the brain scan comes back as being, guess what? Quote unquote, normal. They're not finding anything that is going on. And yet people are still experiencing these particular symptoms. That's how Meniere's is actually diagnosed. It's not because they are finding a distinct lesion or a distinct tumor or a distinct anything wrong in that part of the brain. Meniere's means you have this, but we can't identify what's causing it, and therefore we're going to give it this label. I oftentimes describe these as being functional neurological conditions. So the difference between pathological and functional, pathological being the idea like you've got your computer or whatever device you're looking at this video on, and there's a crack in the screen. You can clearly see that there's a problem. Versus if your device has some malware on it. From the outside, it looks just fine, but you better believe it's affecting the way that it works. Meniere seems to be in that particular category. Now, the interesting thing in terms of the subjects in Dr. Burkhan's research here is this line right here. In addition to the 300 consecutive patients followed from 6 to 14 years at the Meniere's Research Institute, where he was doing the work, over 3,000 peer-reviewed were reviewed and written verification of Meniere's disease from the otolaryngologist was required for inclusion in this study. Why is that important? It means that in this particular study for these people we're going to talk about, these weren't just people who came to Dr. Burkhan per se because they said that they were feeling some of these issues and they thought that maybe this is what was going on because they consulted Dr. Google. No, what he's saying is he's saying that each and every one of these people who was referred in this study had actually had the opinion, the independent appraisal first of the otolaryngologist, an expert in this area, to say it's not any of these other pathological conditions. We are calling this Meniere's. Now, I've had this particular conversation, in a number of different videos, and in fact, one that we did going back earlier this year where we were looking at differences between Meniere's, something that is called BPPV, and what's called a cervicogenic dizziness, where these particular researchers are saying, you know what, these, even though they have slightly different symptomatology, these are really different manifestations of the same thing. And this is oftentimes the case where I will say, you know what, to a certain degree, whatever you choose to call it, whatever, whether you call it Meniere's, whether you call it vertigo, whether you call it cervicogenic vertigo, whether you call it BPPV, whether you call it hydrops, whatever you want to call it, what's causing it? More importantly, what can you do to help it out? That's my principal focus. This is a bit of the aside there, but yada, yada, yada. Again, the people who were vetted for this study, they had independently been diagnosed as experiencing these kinds of things. Now, we already kind of hit on a few different things in terms of, what's going on in terms of the medical treatments or, surgery if it comes to that. But what did Dr. Burkhan actually do? So Dr. Burkhan, he does work very, very similar to myself. Hence why we do this video, because we understand this stuff and so we can translate it into English. We're what's called upper cervical chiropractors. And this means that, no, we are not twisting, we're not cracking or stretching or doing anything to the neck. No. What we do is we focus and we're looking to see what is the relationship of the vertebrae in the cervical spine, with particular emphasis at the C1 and the C2, the top vertebra in the neck. Now, why might we do this? Well, it's because this area, not just from a mechanical or a structural standpoint for pain, as an example, but there are an abundance of nerve cells in the neck that tie into and go to the exact same centers of the brain that are responsible for balance and equilibrium. And I've said this for a very long time, that the three primary sources of input for balance, equilibrium, hearing as well, are going to be from number one, your ears and your inner ear organ. The second one is actually going to be your eyes. And the third one is going to be your neck. To a large degree, it is a sensory nerve organ. Now, if you have, as many people do when they first start to experience the vertigo, what do they do? Who do they see first? They see their GP. They see their GP, and then they may see the neurologist, in which case they're having the brain MRI. If there was a problem with the inner ear, where you could clearly see the accumulation of fluid, where you could clearly see a lesion, where you could clearly see a bleed, something like that, guess what? It would show up. And guess what? Sometimes it absolutely does, in which case, all right, there may be something else going on, needs a different approach. But huge amount of people, their scan appears to be quote unquote normal. So what might they do? Well, if they have eye issues, they may go back to their ophthalmologist or their optometrist, get their eyes checked just to make sure that the prescription is up to speed, because indeed, the eyes have a huge input in terms of balance. Even me, why do I wear glasses? I have an astigmatism in this eye. And it makes everything very blurry. If things are very blurry, then that can start to affect your balance. But let's say then that your optometrist said, no, I don't think this is what's going on here. Well, what then is the most likely next culprit? It's the neck. And unfortunately, this is so terribly overlooked. So this is what we are looking at. We are looking at to see, is it possible that something amiss in your neck, even if not broken, dislocated, bleeding, any of the sort like that, is something perhaps offset just enough that it's sending your brain crap information with regards balance equilibrium? And if so, the idea is that by making precise series of corrections to help realign, restore the motion, but most importantly, over a period of time, stabilize that area, it basically allows everything to start to heal the way that your body is supposed to work. And as that occurs, our expectation and the principle is that these different things that are related start to just sort of dissolve and go away because the body heals itself. Now, Dr. Burkhan makes a very fascinating relationship. Meniere's Research Institute has established a link between whiplash that he is defining as vehicular accident or fall to the head and Meniere's disease. The mean average from the time of the trauma to the onset of symptoms is 15 years. That's a very interesting observation right there. Now, I'm going to back up a little bit, and I'm actually going to offer my commentary for where I don't fully agree with Dr. Burkhan on a couple things. Why is that? Because this is my video. I can say what I would like to see as long as I can back up what I'm saying. Firstly, whiplash doesn't have to be caused by a car accident. It can be caused by anything where your head snaps forwards and backwards, or backwards and forwards, or side to side. Car accidents, super common. But sports collisions, a slip, a bump, a knock, any jarring force to the spine where your body goes like this, that's quite more than sufficient to actually cause some of these issues. Now, the other bit then in terms of 15 years, that's also very interesting because very frequently from a medical diagnostic perspective, we're looking for direct linear relationships. That is, A happened right here and then B immediately followed it. And so we can make that correlation, the association like that. But when we're talking about, seeing this accumulative amount of damage, well, this is different. And the way that Dr. Burkhan is able to, come up with this kind of information, I'm jumping ahead to the very end of the picture right, or the report right here, is two things. One, he's eliciting a history. He's asking people, even if you don't remember, did you have an injury going back in time? But the second thing that you can do is you can have a look at a person's images, whether it's x-rays or CTs, and you're looking to see, is everything nice and normal, or is there perhaps rust, signs of physical damage, signs of trauma? So like if you were to see a bike that's been left out in the rain for a little while, you can tell if that thing has been out there for a few weeks or a few years or even a few decades. So the same kind of thing. Now, I would look at this particular X-ray scan, and I would say that's actually quite more than 15 years worth of damage. I'd say that's more consistent with 25 or so. But nevertheless, a person may come in and they say, no, I don't remember ever having a trauma. No, I've never had anything. You know what? If their picture looks like this, the picture doesn't lie. The individual just simply doesn't remember. So we can find these things out. So very interesting that he finds that there is this association between a previous neck injury and then the onset of symptoms. But because there is that time gap, so often people might say, Doc, I had this happen a really long time ago. Do you think it could be connected? And people, no, that's not the case. Dr. Burkhan's research and my own experience as well, yeah, that is very commonly the case. The past injury sets the stage for what happens years or even decades down the track. And we can't just dismiss these things as being insignificant because there doesn't appear to be that direct linear relationship. So, what does he do? Well, first he does a series of neurological assessments, the same kinds that we do. If you're reading this using what's called a Titron C3, oh, that's an interesting typo. It should be a 3000. How do I know that? Because I have one of these instruments. So, fun little typo, the things that you discover as you're doing a live video here. Neat. It's a heat detecting instrument, heat being a function of nerve and muscle activity. We do a few series of images. In Dr. Burcon's case, he's taking a series of views similar to the ones that we use in the practice. And the point is that we're looking for more than just broken bones and dislocations. We're looking for very subtle and very small joint offsets. And from a, again, pathological point of view, cracks in the screen, oftentimes medical radiologists and whatnot, bless them for this, they're not looking for these things. They're looking for the major signs of trauma, the gross dislocations, the fractures, the bleeds, the tumors, the lacerations. They're not looking for the 2 to 3 millimeter misalignments between two individual vertebrae. And sometimes the remark is, oh, no, that's too small to actually cause any issues. Well, I would argue that very frequently 2 to 3 millimeter misalignments, they represent a 20 to 30% displacement from the normal relationship. Moreover, when you consider the sensitivity of the neurology in your neck, that, well, as one example here, have you ever gotten a piece of hair in your eye? How thick is a piece of hair? Well, it is 0.15 millimeters. So we're talking about things that are upwards of 10 to 20 times larger, affecting the exact same kinds of neurology. Because interestingly, whether it's, the sensors in your eye or the sensors in your neck, they're constructed exactly the same to be able to detect these minute differences. So even the very small things can cause disproportionately large results. So what we do is we go through these physical tests, we go through these neurological tests, we go through these diagnostic images, and we're looking for the subtle stuff that's probably been missed prior. And from there, that helps us then understand, okay, well, if, for example, the neck has been traumatized this way and something else has been traumatized that way, those are the areas where we need to focus our attention and care. And by knowing those details, oftentimes it's going to be very different from needing to crunch or twist or do anything like that. This is not, general manipulation, general chiropractic. No, we find out and then deliver something that is custom tailored to your individual needs. And when you do that, you don't need to use huge amounts of force. Think about it. If you've got, the key to your front door, you put it in the lock and you just turn and you should expect the thing to open. You don't have to shove the key in and give it a really hard twist and a yank or a crank. If you get the right cut, the right fit, it's going to be able to work almost with ease. It's the same thing that we're doing, which makes this work, very, very different. So what did Dr. Burcon do? Well, what he does is he goes ahead and he starts working with these people, correcting these misalignments in their neck. And this he kind of mentioned through here. A couple of little details is that he finds that, with a Meniere's, it's very frequently not just one issue. What he's finding is that there's one issue high up and that there's another issue slightly lower. And what that seems to be doing is, if you would, it's sending two bits of information to the brain at the same time saying, okay, hey, you go this way. And if the brain then receives that information to those balance, hearing, coordination centers, it's like, okay, what? Conflicting information. What then is a person very likely going to experience or feel? They don't know whether they're coming or going. Okay, well, there you can potentially go with the vertigo. If it's to the auditory centers of the brain and it's getting static, like, we don't know what to make of this, well, there's potentially your tinnitus. And if it goes to the centers that are responsible for muscle tone, particularly those muscles that are responsible for maintaining the patency of your inner ear, you can get, for lack of a better description, a blocked ear sensation where, just simply put, you're not properly hearing out of that one side. So he took good records here, and he found that when people were starting out, their vertigo on a scale of 0 to 10, it's up there. And, I say this frequently, that, when people experience sciatica or low back pain, to a certain degree, you can block that out. Same with headaches, although it's harder. Migraines are, harder yet. You can't really do it properly, especially if you can't see, if you got nausea. But vertigo, there is no blocking that out whatsoever. It's impossible. Um, Even if a person is not experiencing true blue vertigo, if they're experiencing dizziness, the sensation that their body is moving like this, the effort that they have to do just to be able to stand upright and not fall over is most exhausting and most life disrupting. So these are not, if a person's never experienced these, please don't. But these are not pleasant experiences that people go through that can really debilitate, completely incapacitate, debilitate them, even though from the surface, so many of them look completely normal. So patients reported inability to function, that is drive, work, or socialize, 50% of the issues. So after 6 weeks, you had, basically 150% reduction, which is not a small amount. So yes, people are still having, vertigo, but markedly less severe or markedly fewer episodes. And that's after just 6 weeks. This is something that I do need to say to people. As much as we love it, snap of the fingers, boom, problem solved. Yes, it does happen. It's impossible to predict. Most people, their healing is a methodical and a deliberate process. So if it took you 15 years to get there, guess what? It's probably going to take you a while to reverse that. Even if you slam on the brakes of a runaway train, it's still going to skid in the wrong direction for a period of time before it comes to stop, let alone actually has that opportunity to start going back in the correct direction. And, one of the things that I also advise people when they do experience, vertigo dizziness, and this, of course, I can't diagnose anybody over the internet. It is simply that no matter what you're doing, you've got to give it a fair go for 12 weeks. Because if it's going longer than that, but you're not getting any functional improvement whatsoever, you could be doing the right thing, but the wrong order. And so you've got to figure out what it is that's interfering with your body's ability to heal. But if you're not willing to give it that length of time, especially if you have that appreciation that even if you only started to experience that vertigo a week or two ago, that if the problem has been coming on for 15 years, if you're not willing to give it at least that 12-week period, you're setting yourself up for failure and disappointment. And that's really with any form of health or medical care that you would do. You got to give things a good, proper, fair go. And that said, many patients, they noticed something was different before they left their office after their first adjustment. Long it took for a person to report a noticeable difference was 14 weeks. That's starting to get there. And the only negative side effect noted was an increase in the frequency and magnitude of headaches in 9 of those 300 patients. And that's not surprising because one of the mechanisms that's believed in vertigo is that you have disruptions with blood flow to the head. So if and when you start to have changes in circulation, do you think that that's possible as things are starting to wake up, that it can actually produce or be involved with a bit of a headache, sometimes even a migraine? It's not pleasant. We don't like it. It'd be ideal if you could avoid these things, but it does not always work that way. Once any procedure is done, it is out of the doctor's hands, and it's up to the innate wisdom of your own body to decide what is most appropriate to do thereafter. The improvements in these patients made a significant difference in 291 out of 300 patients, affecting whether or not they could work, drive, have a positive relationship with their spouse. They might still get dizzy, but they would not have the vertigo. They might still get nauseated. There's another interesting little typo because there's a difference between nauseous and nauseated. Useless trivia for you. Nauseous, when a person says, I'm nauseous, think of it like you have a bad odor. You are making the people around you sick. That's what that actually means when you say, I'm nauseous. The correct language is actually, I'm nauseated. I feel gross and queasy and all of that nasty stuff. So if you've been sticking with the video so far this year, here, you learned some bonus little step there. So they might get nauseated, but would no longer vomit. For those that still had vertigo attacks, they occurred less often, lasted for shorter duration, not as intense. Recovery time was also significantly shorter. So it's kind of a big deal. Again, we're not saying that we are curing all of these things. It's not the way that healing works in the first place. But by getting that neck properly, restored as good as we can, it's making a really big difference for helping these people out. All That's a big word for research. All 300 patients showed evidence of upper cervical subluxation upon neurological examination, and all exhibited evidence of a history of whiplash and an existing atlas subluxation in the radiographs. What he's basically saying there, when you're looking at medical research or anything like that, we oftentimes see correlations, and most of the time we need to understand that these things are risk factors. So, for example, not everybody who has ever experienced a whiplash injury is going to experience Meniere's or vertigo or dizziness later in their life. But it does mean that it's an increased risk factor that they can experience this. But what he is finding is that, okay, if you're going to be diagnosed, and if it's the true blue Meniere's, he's saying that pretty much 100% of the time, there's going to be some kind of neck whiplash injury present when you're looking at the films there. And when you start looking at numbers that big, the odds are that it's just happenstance or random coincidence is pretty darn low. There's got to be some kind of a connection there. Now, what he talks about next here, and this, I'm just going to gloss over this very, very quickly. This is more for the people with the analytical brain who want to know the who, what, when, where, high, which ironically is probably not serving you in terms of finding a solution for vertigo dizziness. It seems to be that the more that we think, the more crisscross information, sensory overload occurs, and it actually prohibits a person's healing, especially if dizziness and anxiety are involved. But that said, this should be the background information then to support you if you're looking for the research and the rationale for how is it that the neck is related to Meniere's or vertigo or these other issues. This is then what you want to check out. 90% of neck disorders are caused by trauma. Of these, 85% are caused by motor vehicle collisions. I wouldn't personally agree with that because, as I said earlier, there's all kinds of other silly things that can happen to any number of us, not just car accidents. There is a relationship between whiplash, the cervical syndrome, neck involvement, cervical nerve root irritation, and the sympathetic nervous system and headaches, including migraines. Meniere's disease patients are 5 times more likely to have migraines than the general population. Sympathetic nervous system is, amongst other things, it's your flight, fight, freeze system. It's a little bit more complex than that, but in a nutshell. But what it does is it also has regulation of every single blood vessel in your body. It is what's responsible for blood flow in, but also for the blood vessels to be able to properly contract. If there is dysregulation of this symptom, people very frequently will have a number of very peculiar symptoms in their body, and one of the symptoms commonly associated that is, for lack of a better term, anxiety or a sense of angst. And truth be it, if a person is experiencing vertigo, especially if it hits them seemingly out of the blue, the person who does not feel anxious or concerned about this, that's actually the abnormal person there. Following whiplash trauma, as time passes, there is an increased probability, there's that word probability, not certainty, of abnormal motion or subluxations. In other words, that the vertebrae are not going to be moving the right way. The resulting issue can create chronic inflammation leading to post-traumatic fibrosis and adhesions, scar tissue. This irritation will cause spasms of the associated cervical spinal muscles, which in turn irritates the superior sympathetic ganglion or postganglionic sympathetic fibers. These are nerve fibers that ascend up the front of your neck and that are ultimately going to be regulating blood flow in your brain. Okay? It's also going to be the ones that are regulating how well your brain is able to clear metabolic debris through the lymphatics. So you can appreciate if there's an issue with either the circulation or with the drainage system in your brain, it's going to affect how things are actually working. Additionally, if not properly treated, the lesion will cause ischemia, not right amount of oxygen, leading to chronicity of symptoms, possibly including cervicalgia, which means neck pain, hand numbness, or carpal tunnel syndrome, if you would, high blood pressure, vision problems, dizziness, nausea, headaches, and deafness. Delightful. Now, he also then goes to talk about, in particular, and go back and watch any number of other videos that we've done, particularly the ones that would be related to chronic fatigue syndrome, fibromyalgia, Chiari malformations. These are all conditions that seem to be related where you have something in the neck that's essentially producing tension or pulling on the spinal cord. So it's producing traction. It's producing torquing, particularly of what's called the trigeminal nucleus. This is the cluster of nerve cells that are responsible for sensation of the head, neck, and face, which is why associated often with the Meniere's, you've got various combinations of neuralgias, headaches, migraines, again, whatever you want to choose to call them, whether they're classic, atypical, cluster, they all are ultimately still processed by this same, part of the brain. And again, what matters more, is it what you want to call it, or is it what's creating it, and what can you do about it? All of this saying, look to the neck. It can be affecting blood flow up to the head, up to the brain. It can be affecting blood flow going down from the brain. It can be affecting the cerebrospinal fluid circulation. That is the normal flow of the fluid that protects and insulates, providing the oxygen and the energy so that your brain and your spinal cord, your central nervous system, can work the way that they are supposed to. And if there is turbulence in that fluid where it's not working right, guess what a person's going to feel then? Maybe not vertigo, but I would argue that they're going to feel that local current disruption, and it's going to make them feel, for lack of a better description, like they're dizzy. So all of these different things, again, we're not talking about pathology of the brain. We're talking about how the neck is affecting the way that your body's working, and how Meniere's, vertigo, and these other issues can definitely be connected. So, as Dr. Burkhan concludes, 100% of 300 consecutive patients, so not just hand-picked, this was as they came in, medically diagnosed with Meniere's disease, also having suffered a whiplash trauma, is unlikely coincidental. Furthermore, 90% having a listing of posterior inferior toward the opposite side of the affected ear is significant, as is 97% getting their vertigo under control within 6 weeks. That comment there about 90% having a posterior inferior towards the opposite side of the affected ear, what he's basically saying is that what he is finding when he's looking at his films, let's say a person experiences vertigo on this side, he's finding that when he's looking at their analysis, that in a nutshell, the person has a kink in their head-neck relationship, something like that. And I think that you can appreciate that that kink may have a potential to disrupt blood flow going to or from the head. Now, I would argue, and this is because the details that Dr. Burkhan gives in this particular study, I would use a slightly different method of analysis to coming to that exact same conclusion. And I would say, okay, there's more detail to it than just that. But nevertheless, I'd say that's a pretty compelling argument. Who am I going to argue against a 97% success rate by doing this type of analysis? It's kind of a big deal. All patients with a history of vertigo should be questioned about a history of trauma, especially whiplash from an automobile accident, contact sports injury, or serious falls. Now pay attention to this one. Patients often forget these accidents, thinking that they were not hurt because they did not break any bones and were not bleeding. We have oftentimes nasty physical injuries. Either we think we're all right, or the paramedics, they do a quick check for us, or maybe we get rushed off to hospital, they look for broken bones, and they say, yep, this must be a soft tissue injury. Go home and heal, take some painkillers, anti-inflammatories if you need to. But the argument here is that there's more that can be going on. And just because you don't have the really dangerous, it's going to kill you kind of stuff, does not mean that everything is actually okay and that it may not show up in bad ways down the track, to such a degree that patients with a history of both vertigo and trauma should be referred to an upper cervical specific chiropractor for examination. In other words, make sure that you're getting your neck properly checked out when you've had these kinds of injuries. And if you've already started to experience Meniere's, this would certainly be one of the kinds of care that you should be wanting to have a look at. So I do hope that you have enjoyed this particular video here, that you found it informative. And again, I do recommend that you actually have a bit of a read of this particular research, because it's written so well and in English. You should be able to understand it. But oftentimes, not many people are not even aware of this as an option, which is the unfortunate thing. So on that note, and as we get to the very end here, this is the part where I ask you then that if you found that this was both hopefully a little bit entertaining, not too boring, but valuable, that you do 3 things. Number 1 is that you should click the like and the subscribe button that you see down at the bottom. Why would you do that? Well, it's because it helps the computer algorithms so that this video can get found by the people who need to find it. Number 2 is if you do have a family member or a friend who might be experiencing vertigo, Meniere's, or they're trying to figure out what's happening, send them this video, share this information with them so that they know what their options are. And last is if you might yourself be experiencing this, but you want a little bit more information, what we would encourage you to do then is go over to our website, which is atlashealth.com.au, and check out some of the other articles, blogs that we've written about vertigo, Meniere's, and the number of different conditions that we commonly see for people when what they actually have is they have an underlying condition that's affecting the alignment of their neck, which is affecting the healing function of their body, and that by correcting that and then giving their body that opportunity, that time to be able to heal, that you can actually get about going to getting your quality of life back and enjoying the things that matter most to you. So our website again, atlashealth.com.au. Again, hope you've enjoyed this particular video. Love doing these, and so we will see you again next time. So until then, take care and bye-bye.